it is my pleasure to introduce Dr. Nalini Kaul Mahajan as our speaker today. Dr. Kaul Mahajan is the director of the Mother and Child Hospital in Delhi and the scientific director of the Ferticity Fertility Clinics. She is the founder president of the Fertility Preservation Society of India and a founder secretary of the Asian Society of Fertility Preservation and a board member of the International Society of Fertility Preservation. She's chief editor of the Oncofertility Journal and a convener of the Indian Fertility Society Special Interest Group on Poor Ovarian Reserve. She's a patron and chairperson of the Public Awareness Committee, PCOS Society, and the past president of the Indian Fertility Society. Dr. Kaul Mahajan is a winner of numerous prestigious prizes, presented original work at international and national forums, invited faculty and in national and international conferences, and published extensively, including research articles and chapters in numerous books on infertility, and also a reviewer for leading journals of our field. The title of the presentation will be Optimizing Endometrial Preparation from Frozen Embryo Transfer. And Nalini, please go ahead.
Good afternoon, and thanks, Ariel, for this kind introduction. And before I begin, I'd like to thank Zev for inviting me to speak on such a prestigious panel. And the talk today is on optimizing endometrial preparation for frozen embryo transfer, as you just said. And this is not moving for some reason. Okay. Should I just go back because this has gotten disrupted, Ariel?
No, you can. These can be cut during editing.
All right. Okay. So the reason for the focus or the refocus on endometrial preparation currently is because the frozen embryo transfer cycles are increasing globally, and we have seen an increase of almost 30 to 40% over the last decade. And the main reason for this has been the improved embryo survival, which we have seen with the use of vitrification. Also, that there is more embryo endometrial synchrony that is achieved, and so the pregnancy rates are better. And then there were some papers to suggest that perinatal outcomes were better with FET, and ovarian stimulation actually negatively impacted perinatal outcomes. And so, from the simple indication of FET for supernumerary embryos, we went on to elective cryopreservation to reduce the risk of OHSS, which was very, very valid, and for fertility preservation, and then went on to use it to improve implantation in BRIF and increase pre-ovulatory progesterone. And then while we are waiting for a trophectogram biopsy, if you suddenly encounter some uterine factors during your stimulation, a previous history of ectopic, to avoid donor-recipient synchronization in donor cycles. So, the indications have just constantly increased for FET. And in 2013, there was a review and meta-analysis which suggested that elective frozen embryo transfers resulted in an increase in clinical pregnancy rate with a risk ratio of 1.3, and ongoing pregnancy rate increased by a risk ratio of 1.3, and the miscarriages rates were same, there was no increase. And this led to a review article which said that, listen, let's forget about doing fresh embryo transfers and do everything elective freezing to maximize the dismal pregnancy rates that we have in fresh IVF. However, we all know that successful implantation is not only about the embryo, and there is an endometrial factor as well, and the endometrium needs to be functionally competent to be able to have a molecular dialogue with the blastocyst to allow for implantation. And what happens with the endometrium is that at the time of implantation, it will undergo changes at multiple levels. And these changes are brought about by the action of progesterone on an estrogen-primed endometrium. And this happens about 5 to 9 days post-ovulation And this small window, when this is allowed, when it's allowed for the blastocyst to implant, is known as the window of implantation. And at this point, the endometrium is absolutely ready to have that dialogue and allow the embryo to implant. Now, in a natural cycle, the estrogen is provided by the growing follicle. It leads to proliferative changes. And then with the onset of ovulation and corpus luteum formation, progesterone comes into the picture and allows for the development of the secretory state. And the estradiol levels of about 200 to 300 picograms, which are achieved in the proliferative phase, are thought to be adequate for priming of the endometrium. And in the luteal phase, the progesterone levels that have been seen are about 7 nanograms per mil. But this is true for natural cycles. But what happens when the person is anovulatory, or you don't want to use an ovulatory cycle, or it's a postmenopausal patient? We have to provide this estradiol and progesterone exogenously so that we can achieve this endometrial maturation and a secretory phase to allow for embryo implantation. And so there are two types of cycles which are used for FET. One are the ovulatory cycles. That means you can do frozen embryo transfers in a natural cycle where you track the follicle till ovulation and synchronize the transfer based on the day on your ovulation, with day 0 being equal to day of oocyte pickup. You can do a modified natural cycle transfer where, to avoid this closer monitoring, you can give an HCG trigger when you have a dominant follicle, and this times ovulation, and you can synchronize your freeze-thaw. And then in patients who may not be ovulating in every cycle, or they are anovulatory, you can also give ovulation induction drugs, monitor, give the trigger, and time your embryo transfer. And the drugs you can use are letrozole, tamoxifen, or even gonadotropins, as the case may be. Now, in the anovulatory cycles, you can use exogenous estradiol and progesterone, or you can downregulate or give an agonist suppression and follow this up with estrogen and progesterone. And this really helps very much in cycle programming, and it also avoids the escaped follicle. Sometimes the estrogen is not enough to suppress the pituitary, and you may have a follicle developing even in an HRT cycle. So if you downregulate, then you can avoid that. And what has been seen, and this survey was done by Ariel, is that about 50%, half the number of physicians prefer doing program cycles because it makes life a little bit easier to do the embryo transfer. Now, how do we monitor the cycle? You start with a baseline scan on day 2. The endometrium is thin, there are no cysts, and then you start your monitoring maybe from cycle day 8 or 9. And once the dominant follicle is about 17 millimeters, the LH surge is checked for, and you check for ovulation and start your progesterone. For HRT, this monitoring is simpler. You basically just start from cycle day 9, do a baseline scan, and then you can just start your estradiol and call the patient after 9 or 10 days, and progesterone is added when the endometrial thickness is 7 or more. But please remember, this is not some rule of thumb, because there are some patients who will not reach 7 millimeters, and depending on what is their inherent lining, we have to go ahead with progesterone supplementation. Monitoring of the LH surge in natural cycle is perhaps one of the most difficult things. In the natural cycle, you require very close monitoring, and you can look at the LH surge in urine or blood. The urinary LH surges give a 30% false negative, and they lag behind the blood surge. Now, when you do a blood surge, you still need to monitor with the ultrasound very closely to ensure when ovulation takes place, so that you don't need to cancel the cycle either because of a premature rupture or maybe a premature progesterone rise. And it's very important to remember that patients who have POI or older patients, they tend to have short cycles and they can have premature ruptures. So it is wise perhaps not to use a completely natural cycle for doing their FETs. Now, when we are doing the HRT cycle, as I said, estrogen and progesterone has to be given from outside. And the aim is to actually prepare your endometrium in a way that you open the window of implantation and synchronize your transfer to optimize pregnancy rates. And the window of implantation opens presumably 5 days after progesterone administration, coinciding with blastocyst entry into the uterus. Now, looking at endometrial preparation, we use estradiol valerate, and the routes of administration can be oral, transdermal, vaginal, or injectable. You use the transdermal, vaginal, and injectable routes in patients who have altered LFT or coagulation disorders because you avoid the hepatic bypass effect. And the dose schedule can be either an incremental dose or a constant dose, which means that starting on cycle day 1 or 2, you can start with 2 milligrams of estradiol valerate for 4 days, increase it to 4, and then go on to 6. Generally, a dose of 6 is used. However, you can step up if required, if your lining has not come through. And in the incremental dose, or in the constant dose, you would just start straight off with 2 milligrams 3 times in a day. For the transdermal gel, we just use 2.5 milligrams twice a day, and it's applied on the forearm. You can increase to thrice a day in case your lining is not building up. Patches are also there, starting with 75 micrograms and increasing to 150 micrograms every 3 days, or a constant dose of 150 micrograms every 3 days. Now, the same oral tablet can be used vaginally. It's very effective. The levels in the endometrium are very good. And, wherever patient is unable to take the oral drug, we can give it vaginally very easily. Because earlier transdermal gels were not really available in India, so we used to use this vaginally. Injectable is very, very rarely used, but probably in patients who have thin endometriums which are not responding and you feel that absorption of endometrium of estradiol is not taking place, you can give injectable estradiol valerate as well. Progesterone supplementation is done with natural progesterone or micronized progesterone, and now dydrogesterone, which is the oral progesterone. And the routes can be vaginal, they can be rectal as well, injectable or oral. For vaginal, a dose of 600 to 800 milligrams in divided doses is given. The first pass effect on the uterus is seen. You'll find that the progesterone levels in the endometrium are far higher than in the serum. However, patients who have urinary infections or vaginal irritation or develop vaginal irritation with these pessaries, you cannot afford to use this. Crinone gel can also be inserted into the vagina at 8% of gel twice a day. For the injectable, you have the oil-based preparations, and now we have the aqueous preparations, which are far less painful. And with the oil preparations, the dose is 50 to 100 milligrams per day intramuscular, and we go with higher doses if we have high BMI patients. And with the aqueous, it is 25 or 50 milligrams per day, and the aqueous ones can be given subcutaneous. One of the problems that is associated with injectable, especially with the oil-based preparations, is allergy. You get a lot of allergic reactions, and then of course we have to move on. Fortunately, oral dydrogesterone has been shown to be effective, and the dose of 10 milligrams thrice a day or 40 milligrams a day is very effective as a luteal phase support. So now you've got the estrogen, you've got the progesterone. How are you going to synchronize your transfers or thawing of your embryos in the transfer? So in a natural cycle, the day of ovulation is day 0 or the day of pickup. Day 1 then would be 2 p.m., day 2 would be 2 to 4 cell, and day 3 would be 6 to 8 cell, day 4 would be morula, and day 5 would be blastocyst. So for a day 3 embryo, you thaw on day 4 of ovulation. For a day 5 embryo, you thaw on day 6 of ovulation. In the artificial cycles, the day you start progesterone is day 0 or the day of pickup, and the transfers would be, or thawing and transfer will be done after 3 days of progesterone in a day 3 cycle. day 3 transfer cycle, and after 5 days of progesterone administration when you're doing a blastocyst transfer. So if you look at it over here, this is your oocyte retrieval. So first day of progesterone, second day of progesterone, third day of progesterone, then you thaw and transfer, and similarly 5 days of progesterone, and on the 6th day you thaw and transfer. So it becomes very simple because you time it to ovulation, keeping that as your day 0. So these are the basics in place. How do we optimize endometrial preparation, especially in the artificial cycles? Because as we've seen, 50% of people prefer to use those cycles because of the programming issue. So we need to address some questions here. Does the route of estradiol administration matter? Does the dose matter? Does the length of exposure of estradiol matter? Should we do any hormone estimations like estradiol or progesterone before starting, on the day of transfer? How do we know that what we have built in the endometrium is receptive? And which of the cycles, natural or the artificial ones, will give a better reproductive outcome? So how do we define this optimal protocol? So as I said, you start the endometrial preparation with estrogen. And so what is the dose that we need, and what are the, the type of administration which would be best in terms of reproductive outcome? And this was a retrospective analysis of over 8,000 cycles, where they looked at 2 types of doses, the intraparental and the constant dose, and oral and transdermal routes were used. So now what we saw was that the clinical pregnancy rate, the with oral and transdermal, the ongoing and the live birth with both with the incremental dose and the constant dose were exactly the same. There was no difference. However, when you look at the biochemical pregnancies, it was seen that the constant dose group had more biochemical pregnancies than the incremental group or the transdermal groups. And this difference remained even after an adjusted analysis was performed. Now, in this study, they also looked at the length of estrogen exposure, but their exposure was between 12 and 15 days, and they did not see any significant differences in the reproductive outcomes. And they felt that the variables like BMI are perhaps far more important than the length of estrogen exposure. But there were others who did not necessarily agree with this, and it was seen that shorter estradiol replacements of less than 11 days led to higher miscarriage rates. It was also seen that longer replacements, more than 40 days, led to breakthrough bleeding. In our setup, we find that after 19 days of administration, the breakthrough bleeding increases. Live birth rates were significantly lower when the estradiol levels were given for more, estradiol value was given for more than 28 days, or the clinical pregnancy rates were reported less when estradiol was given for more than 20 days in non-down-regulated cycle. And so there were others who said the best reproductive outcomes are between 6 and 11 days, 11 and 40 days. So if you sort of overall look at the overall picture, what I came to the conclusion that 11 seems to be a number which is recurring. So 11 to 19 days, depending on the cycle length, would perhaps be the best time of length of or duration to give estradiol, so that there's no breakthrough bleeding, and also there is enough progesterone receptors in that endometrium. It's well primed for progesterone action. Now, another study also looked at the length of the duration of estradiol administration, and what they found was that it inversely correlates with gestational age at delivery. That means the more estradiol you give, the lower gestational age will be seen, and they felt that perhaps the high estradiol level has an impact on placentation but not implantation. And we can really agree with this, because if we see supraphysiological levels of estradiol in IVF are associated with an increased incidence of pregnancy-induced hypertension or preeclampsia. So having done this, let's look at the hormonal values. Do the estradiol values matter at all before we start progesterone administration? If we had a certain level of estradiol, would it be better in terms of achieving the secretory changes or the implantation changes? And there are very few studies, and most of them are retrospective. 4 studies said that there was no impact at all on reproductive outcomes. There was only one study which said that high levels of estradiol did impact the biochemical pregnancy, clinical pregnancy, and ongoing rates. And to look at a little more closely at this retrospective, very recent retrospective analysis was done on over 1,000 cases, and they grouped the patients into 3 groups based on the estradiol levels: less than 144, 145 to 438, and more than 439. And what they found was, and this was before you started progesterone, and what they found was that it showed there was no difference in the live birth rates in any of the groups. And so you cannot really say that, okay, here, look, let me do the serum estradiol level, and I can base my clinical decision in terms of stepping up estradiol or prolonging the cycle or canceling the cycle based on estradiol levels, and you cannot really recommend its use. Progesterone, we know, is the all-important hormone of pregnancy and implantation. It causes the secretory changes, it opens the window of implantation, it causes uterine relaxation, it immunomodulates and leads to pregnancy sustenance. However, we are still nowhere in getting a very clear clarity or consensus on what is the optimal dose, the duration, the route, or what are the levels we should achieve to have optimal pregnancy rates or reproductive outcome. Now, when LPS was started, really, we found that in IVF, basically the luteal phase was defective and we needed supplementation. So these doses that were, sort of established, these were established in IVF cycles. And these were like 600 to 800 milligrams for vaginal pessaries, 8% for non gel. In fact, it started with an OD dosage, but then that was not seen to be very good. And so it increased to BD, and 50 and 200 for injectable intramuscular, and 25 to 50 for subcute. But these were all built on or based on the reproductive outcome that you saw in IVF and not on any progesterone levels. Recently, oral dydrogesterone has also proved to be a very beneficial agent, and there's a non-inferiority trial, Lotus 1 and 2, which has shown that if you give 30 to 40 milligrams a day, and this has been defined for fresh embryo transfers, your pregnancy outcomes aren't going to be as good as with other routes. In fact, in some states, it has been proposed to be better. Now, what is the comparison between these routes? Seems that they are all similarly efficacious, and these levels were then extrapolated to the frozen embryo transfer cycles or the HRT cycles, where you didn't have, where you still needed to give progesterone. So you took it straight from there and extrapolated it there, and it worked fairly well in the HRT cycles as well, except for oral dydrogesterone, where we don't have enough data to say whether we should use it exclusively to replace in place of the luteal as a luteal support. Now, a very interesting paper which looked at the minimum concentration which was required to induce the secretory development and receptivity, which was induced by progesterone. And in this paper, what Yang et al. Did was they did a down-regulated HRT cycle, gave 10 days of estradiol valerate, and then gave progesterone in oil in 4 different doses and took a biopsy on day 23 of the cycle. And what they found was, with the value of 40 milligrams, the progesterone concentration peak and trough 18 and 9, which was established or which was seen, it was observed to be very similar to what we normally see in a mid-secretory phase. And more interestingly, the histological dating and the endometrial gene expression was very, very similar to the natural cycle. So proving thereby that giving 40 milligrams of progesterone in oil is perhaps the minimum dose you need to give to affect those secretory changes which are good for implantation. What about the optimal luteal phase progesterone levels? Now, a lot of work recently, there's a lot of interest in doing these levels. And so far, what we have understood is that for fresh cycles, you need, if you have progesterone values which are above 30 nanograms per ml, then the pregnancy rates are better. And if you have in frozen embryo transfer cycles, 15 to 30 nanograms value, then the pregnancy rates are going to be better. Lower than this would increase your miscarriage rate and decrease the pregnancy rates. Now, again, in a recent study, an optimal cutoff value for prediction of ongoing pregnancy rate was defined as 20.6 nanograms. This was done in artificial cycles with euploid single embryo transfer. So more or less 15 to 20 is what we are looking at in terms of the luteal progesterone levels, which seem to be good in terms of reproductive outcome. But what happens with vaginal? We know that vaginal preferentially goes to the endometrium, and so the serum progesterone levels are much lower. And what, in this very nice article by Labata, what she found was that the progesterone value of 9.2 nanograms per ml needs to be reached on the day of ET. Otherwise, if it's lower than that, you have significantly lower ongoing pregnancy rate, and the endometrial volume was not really related at all to the pregnancy rates. These were artificial cycles or HRT cycles, and the progesterone given was 400 milligrams vaginal twice a day. Now, in a follow-up of this study, very interestingly, what she found was that if you actually increased your progesterone supplement on the day of ET, if your values were lower than 9, then you actually improved the pregnancy rates and got them up to the same value as for those patients whose progesterone levels were higher. Perhaps this is the reason why it is proposed that when you're using dydrogesterone or vaginal progesterone, they're not effective as monotherapy and should actually be used in a combined setting. In Europe, of course, vaginal progesterone is really used exclusively. However, in India and in the States, I know we do use a lot of intramuscular or injectable progesterone. And personally, I do like to combine the two so that we get effective progesterone levels, because with so much infection that is prevalent here, we really don't know what is the absorption level from the vagina. What about a premature progesterone rise, and does it matter at all in HRT cycles? We know that in the natural cycles, in 25% of women going for modified natural cycles, the progesterone levels are already have risen at the time of HCG, and about 8% of cycles would roughly be cancelled for this reason, because it would interfere with endometrial receptivity. So many a time GnRS agonist is used to prevent this. But for HRT cycles, it has been suggested that you should try and start progesterone when the supplementation, when the serum progesterone levels are lower than 1 nanogram per ml. However, everybody has a counter opinion, and Greenwood suggested that actually it doesn't matter, because in 24% of the people, progesterone level is definitely elevated in natural cycles, and in 44%, both progesterone and LH is high, and so therefore really you don't need to do this testing at all. However, if you see here, the live birth rates were really very low, and one does not know what to should one really count this as a true picture. Somebody else did another very interesting study, and what they said was a rise in progesterone on the day of the LH surge doesn't really matter, but if the progesterone has been elevated for at least 2 or more days before your LH surge started, the resulting pregnancy rates would be lower. However, in clinical practice, this is all right for the study, but in clinical practice, we cannot keep on repeating progesterone levels so frequently, both the patient will get fed up and cycle cost would be so expensive, but it's very good for as a knowledge base as to what happens with progesterone. Now, having done all of that, which cycle should we use? This very important and interesting meta-analysis done by Greenwood in 2013 compared all types of cycles. And when he looked at true versus modified cycles, you can see there is no increase in clinical pregnancy rate, ongoing pregnancy rate, or live birth rate between the two, and these were almost 2,000 cycles. Then he added luteal support to this, so a comparison of the natural cycle with or without luteal support, again, no difference at all. All the clinical pregnancy rates remained the same. When you looked at the modified natural cycle as opposed, or the natural cycle as opposed to the artificial cycles, and again, a large number of patients, you again found everything in the center line, that there's no increase in clinical pregnancy rate, both are the same, ongoing pregnancy rate or live birth rate are the same with both types of cycles. There was one outlier here, and one person who said no, the miscarriage rates do increase in the artificial cycles, and we'll talk a little bit more about this. Now, again, the natural cycle versus the artificial cycle, a subgroup analysis where luteal space support was added in the natural cycle, again showed absolutely no difference. So that means you did the natural cycle with or without luteal support. It was the same as the results or the pregnancy outcomes were the same as doing with an HRT cycle. Again, natural cycle versus a down-regulated artificial cycle, no difference in it, any of the outcomes. And artificial cycle versus artificial cycle with GnRH agonist, again, no differences in clinical pregnancy rates observed. Now, he also went on in 2016 to do a randomized control trial, because in the previous cycle, in the previous meta-analysis, he had also taken retrospective studies. And again, he said that this is a there is non-inferiority of the AC cycle over the modified natural cycles. So you can use either, they're all the same. And this was further updated and, the same with the same results in 2018. And the Cochrane database analysis also told us that, look, there is insufficient evidence to support any particular intervention for endometrial preparation, and that would improve your treatment outcome. And you can use for progesterone, vaginal or intramuscular, it's going to be exactly the same. One trial did show higher results with natural cycle as compared to the artificial cycle FETs. And GnRH agonist, even though it was reported that there is no difference whether you used it or not used it, my contention is that in patients with adenomyosis, we know that long-term suppression always improves pregnancy rate because of the shrinking or improvement in the contour of the uterus and decrease of the adenomyotic glands. And perhaps that is one area where we should rethink, the GnRH agonist use. Now, as I said, the moment you say, now everything is okay, all cycles are the same, and we are going to use that, somebody comes up with something else. And in this paper in 2018, which was done comparing the HRT cycles with the ovulation induction cycles, it was shown that the early pregnancy loss was higher in the AC cycles, that is the HRT cycles, as compared to ovulation induction, and the live birth rates were significantly higher in the ovulation induction cycles. So many controversies still exist. Some say the natural cycle is better as compared to modified natural cycle. With and without LPS, the pregnancy rates are lower. Ovulation trigger is good. Some say ovulation trigger reduces the pregnancy rate, especially if the LH is higher at the time you've given the trigger, which means that you should be doing your LH so frequently. And even there have been studies to say that you should actually give progesterone for 6 days before you actually think of doing a transfer. So still, everything is open out there and a lot of controversies exist. So how do we decide? And perhaps we need to look at what are the advantages and disadvantages of the various protocols. And when you look at natural cycle, the biggest advantage it has is the endometrial receptivity is highly improved in that, and it is as compared to the artificial cycles, because there is a strong effect, negative effect on gene expression, which is there during the endometrial receptivity window. So this is a very, very strong contender for going towards natural cycle FETs. Now, it has been suggested that FETs, give you less SGA, or low birth weights are improved. However, with FET, you also have increased risk of PIH and large for gestational age babies, along with whatever other complications they carry. So this, does the type of cycle actually change this? And this was brought about by this population-based study from Sweden, which said that pregnancy outcome, the neonatal and maternal outcome after frozen embryo transfer in natural or stimulated cycle is much better than what you have in the artificial or the HRT cycles. You have more PIH in the artificial cycles. You have more PPH, post-term births, macrosomia in these cycles as compared to when you're using simple ovulatory cycles. And this is perhaps related to the hypothesis of an absence of the corpus luteum. It is believed that the corpus luteum, apart from estradiol and progesterone, secretes relaxin, which affects the maternal, systemic, and renal vasodilatation and increases the GFR in pregnancy. So basically, it affects the vascular health in early pregnancy, and its absence increases the risk of preeclampsia because it leads to a whole lot of alterations. And interestingly, the relaxin secretion from the corpus luteum in letrozole cycle is lower than in clomiphene cycles. So when we are using these ovulatory induction drugs, maybe this is something we need to bear in mind. In HRT and downregulated HRT cycles, the biggest advantage is cycle programming, but unfortunately, the cycle becomes lengthier. You have, you may have escape. Your follicle may come up and you'll have to abandon the cycle. And the luteal phase supplementation, the estrogen and progesterone supplementation really goes on for much longer than what you would do with a natural cycle. So therefore becomes more expensive and cumbersome. So we've got this beautiful lining, and the marker, endometrial marker that we take for receptivity, which we use clinically, is the sono ultrasound, the triple line, 7 mm, volume, vascularity. But we know that it's not prognostic. It's prognostic and not predictive. And we know that in 20 to 25% of the HRT cycles, the window of receptivity or window of implantation is altered. So is there a way around it? And we can look at transcriptomics. We have a beautiful test available now. We can look at the transcriptomic signature of this window by doing an error test, and therefore personalize the embryo transfer. And with a personalized embryo transfer, your implantation and pregnancy rates would improve. Are there any other methods to improve endometrial receptivity? Of all the methods that are there and used, what I'm finding is that the intrauterine, installation of the platelet-rich plasma seems to affect not only the endometrial thickness, but also endometrial receptivity. And we are looking at it at this point in patients who have failed embryo transfers with the personalized embryo window that we have established, and to see if PRP helps those patients to get better pregnancy rates. And so to conclude, I would say that at the moment, all protocols are supposed to be similar. The natural protocol has advantages of improved receptivity, lesser complications, and lesser medication, though it's difficult and cumbersome to do. The modified natural cycle actually helps you to time your ovulation and therefore becomes more convenient. The artificial cycles, definitely regulation is better, less monitoring, but associated with more problems. And the optimal form of progesterone supplementation has still not been established. And we are looking at progesterone levels and trying to define a value for them, which would, on the day of starting progesterone and on the day of ET, which would improve the endometrial receptivity and pregnancy rate. So far as the estradiol levels go, they're not helpful at all. So for the moment, patient's preference, convenience, and cost need to be considered. And all that we have looked at, maybe you can sort of amalgamate, put it together, and try to improve your cycles as best as you think is applicable to your patients. And with that, I'd like to thank you all for listening in.
So thank you very much, Nalini, for this excellent, very clear and comprehensive presentation. I have only just very few questions to clarify things. So for a 35-year-old ovulatory patient who comes to your clinic and she's about to have a frozen embryo transfer, what would be your personal preference as a protocol?
For a 35-year-old patient, I would actually like to look at her cycle. What I normally do, Ariel, in my practice is I monitor a natural cycle for every single patient, whatever I do, because that gives me her endometrial thickness that she is going to have. I would know whether her cycles are ovulatory and when she ovulates. So with that background, I would, and any other infertility factors she has, my preference now, earlier if you had asked me this question, I would have told you I would give her an HRT cycle because that is what I was primarily using. But since the last, I think it's almost 6 months now, I have moved more and more towards the ovulatory cycles because it's not always possible to transfer in a natural cycle because you may not have a follicle at all and then you waste the cycle. So I do like to give ovulation induction drug, monitor, give an HCG trigger, and time synchronize my transfer to that. However, if I'm very sure that patient has nice ovulatory cycles and she tends to ovulate in every cycle as has been monitored for long, then I may even consider doing a modified natural cycle, frozen embryo transfer. So that's the way I would look at it.
Thank you. And is there an age limit for conducting a natural cycle? Would you trust the ovulation of patients with advanced maternal age? Would you allow them also to have a natural cycle?
The problem with advanced maternal age is that they tend to have short cycles, and you may have a follicle of 15 or 16 on one day, and the patient comes next day and the follicle is gone. So you really don't know when she ovulated. So those are patients I would really not risk doing ovulatory cycles. But it's not that it can't be tried because it's not expensive, and monitoring in India is very cheap. There's no problem, and all you do is waste a cycle. But I would, for those patients, prefer to go with HRT cycles because of this aspect of shorter cycles and premature ovulation, and also probably a luteal.
Yes, and regarding the length of luteal support, what would be your preferences regarding the duration of luteal support in both natural ovulatory cycles and artificial cycles? How long would you support the luteal phase?
In the natural cycles, I definitely support till the 8th week, though I may start reducing the amount of progesterone given once I have identified the sac and seen a cardiac activity. And after 8 weeks, I gradually taper it off. In the HRT cycles, it's a little more worrisome. So we do give up to 12 weeks. However, again, once at 8 weeks that luteal-placental shift has occurred, I start tapering off the dose so that by the 12th week, the person is not on any kind of support. But just to say that, we to share with you, I've seen that it really doesn't matter. Sometimes we are forced to stop the estradiol and progesterone. Like I had some patients who had DVT, and there was no option but to stop the hormonal replacement, and they went ahead to have a perfectly fine pregnancy. So I think it's something that we worry about more than actually what physiology dictates.
Okay, and the last question is not related to the topic, but generally about the COVID-19 pandemic. How is it affecting your practice? Are you back to work now? Could you elaborate briefly about that?
We are struggling. We initially, when one didn't know the nature of the virus, we had actually told patients to stop their cycles and wait for a while till things got better. But once you realize that it's not something that's going to disappear overnight, we started with doing simple FET cycles, and of course ensuring that the patient was well, there were no other issues, looking at all their blood work, much more blood work than we ever do regularly for FET cycles, and then went on to do the cycles. For patients, now we have started, the pickups again, and we are doing the COVID testing before they go in for anesthesia, more because frankly the anesthetists worry because they're on the head end of the table than for us, because in India the guidelines are that you should test only if the patient is symptomatic and not if the patient is not symptomatic. So we are limping back to normalcy. I don't say that we are back there yet. We do worry because if during pregnancy the patient develops COVID, we really, pregnancy is already a state where there is immunomodulation happening, and there is immune changes, and you really don't know how the body is going to react. There have been pregnancies with COVID, there have been deliveries on patients who are COVID positive. So far, no major stuff has happened, but it's early days, and we really don't know whether the miscarriages are going to be more or what's going to happen.
Okay, so thank you very much. It was a pleasure, and we hope to get to normal promptly and to see each other in live meetings. Thank you once again.
Bye. Bye.
Bye.